the nurse calls you about Mr. Montgomery Burns. I think probably in Brazil you recognize him too. He's a 71-year-old man with cellulitis. He has a history of hypertension. He's on 2 medications and has a prior myocardial infarction, an MI, and had a stent placed 3 years ago. You call the nurse back. He has an increased blood pressure, but no symptoms. And you're not concerned about end organ damage, right? He's not complaining anything, no vision problems, no chest pain, no headache at that time. He just has the cellulitis and his leg hurts. At what systolic blood pressure would you administer an as-needed antihypertensive? So how high does his blood pressure need to go for you to give him some IV hydralazine or labetalol or something like that? So what's your cutoff? 160? Does he have to have a blood pressure of 160 millimeters of mercury for you to want to give IV hydralazine or labetalol? How about 180? That's getting up there. 200? If his blood pressure was 200, would you give him the IV labetalol or IV hydralazine? Again, he's without any symptoms. How about 220? Wow, that's really high. How about greater than 220? Think about that. If you got a call about a blood pressure of 230 in Mr. Burns from the nurse, would you give the IV hydralazine? Or would you wait for his head and kidneys to explode? What would you do? So we administer as needed antihypertensives in the US for hypertensive urgency all the time. But first of all, does hypertensive urgency even exist? Well, here's the definition that people will often use. That's systolic blood pressure greater than 180 or the diastolic blood pressure greater than 110. And most importantly, they have no end organ damage. They don't have any symptoms from the blood pressure. So they got really high blood pressure, but no symptoms. That's what people will call hypertensive urgency. But what does that mean? So it should mean that if your blood pressure is in the urgency range, then we need to do something relatively soon or something bad is going to happen, right? We wouldn't call it urgency unless there was an urgency to treat it. And of course, that something bad is things like acute stroke, myocardial infarction, aortic dissection, hypertensive encephalopathy, PRES, pulmonary edema, that sort of stuff, right? That's what we're worried about. And we're worried that it's going to happen soon. Over the next few hours, there's an urgency to treating it. So why would we treat it? Well, of course we would treat it because we know that the treatment of severe hypertension reduces the risk of death, myocardial infarction, stroke, among other things. We know that. That's why we treat high blood pressure all the time. And certainly up to date, which I know you guys probably use as much as we do, they say lower the blood pressure over a period of hours to days rather than longer periods of time. So they say you should get this done, treat it urgently. And I think the current standard generally says, because this is what people do, is that we ought to treat. And the most important reason we're going to treat is because you will keep getting paged about it by the nurses. They are not going to let it go, right? That 190, 200 systolic, if you don't do anything about it, you're going to hear about it. Or you're going to see in the chart, doctor informed and doctor didn't do anything. So let's look at some studies about treating high blood pressure. Now, one of the first big studies in the United States about treating hypertension and its improvement on morbidity came out in 1967 in the Journal of the AMA. And they looked at 143 patients who were VA patients who had severe diastolic hypertension, because at that time, we thought diastolic blood pressure was really the key to it all, and that systolic didn't really matter. So they treated them with old-time drugs, although certainly we use hydrochlorothiazole all the time, and for some reason my residents use hydralazine all the time. Not too much reserpine going on, except for maybe our pregnant patients. Or they used placebo. And these were patients, look at them, these were patients who had really high blood pressures when they were enrolled. They had diastolics in the 120s and systolics in the 180s. These were high. So in 1967, you could randomize whether you were going to treat this or not. Obviously, today, we could not randomize something like that. And what they found was if you did treat these patients, it worked. It got their blood pressure down at 4 months and 2 years. And if you didn't treat their blood pressure, well, then their blood pressure continued to remain really high with diastolics in that 119, 120 range. So did it make a difference in terms of morbidity? The answer is absolutely yes. Look, in that treatment group, only 2 patients had some sort of complication. And in the placebo group, a whole lot of them had complications, right? Treating blood pressure was really important. But, and the number needed to treat here was really low. Any event was 3, death, stroke, CHF, MI 5, meaning you only had to treat 3 patients to avoid any sort of event. So that's amazing. But that happened over 1.5 years, not hours, 1.5 years. So these were all patients with hypertensive urgency when they got into the study. And the bad things happened over 1.5 years. And in fact, the time to the first event for any of the patients was 1 month. And that was actually in the active treatment group. The first time to an event in the placebo group was at 2 months. Right? So when you're getting called about these blood pressures of 180 over 120, know for the most part that if this is a chronic problem for that patient, you've got months to figure this out, not hours. So giving IV hydralazine or IV labetalol right at that time doesn't make a big difference for the patient. It's the treatment over time that is going to make a difference. So this was also a really interesting study and a much more recent study than that 1967. This came out from the Cleveland Clinic in the United States, where they looked at about 60,000 patients who were going through their primary care clinics. And they wanted to look at patients who came into clinic with blood pressures that would qualify as hypertensive urgency and what happened to them. What did the doctors do? And what they found was there were about 60,000 patients during this period of time that had hypertensive urgency. So how many of them were sent to the ED of the 60,000 patients who showed up in their primary care doctor's office with hypertensive urgency? Less than 1% of them were sent to the emergency department because it's not an emergency. This again is a problem that happens over weeks to months, not days or hours. How many of those patients were admitted? 100 patients overall, 0.2% of the overall cohort. And what you'll see is for the patients who were sent home or the patients sent to the hospital, almost all of them had the same risk of having a major adverse cardiac event. In fact, you were more likely to have a major adverse cardiac event if you were sent to the hospital because someone knew that you needed to go, versus all those patients who were sent home where 0.1% had a major adverse cardiac event at 7 days. That's 1 in 1,000 patients had some sort of bad cardiovascular outcome within the next week. Well, if 180, right, 180 is our cutoff for hypertensive urgency, how about if we just looked at the patients who had a blood pressure over 200? Well, 6,000 of them were sent home, and again, only 0.2% had a major adverse cardiac event at 7 days. Again, really few. How about ones who had greater than 220? Can you imagine seeing a patient in your primary care clinic with a blood pressure greater than 220 and you sent them home? Well, 1,000 patients were sent home and 0.2% of them had a major adverse cardiac event in the next week, 1 in 500. So adverse events from severe asymptomatic hypertension appear to accumulate over weeks to months, as I said, not hours. And there have been a few different hospitals in the United States, UCSF and Mount Sinai, who have done, and this was published in the Journal of Hospital Medicine, where they tried to make sure that their patients did not get as needed antihypertensives if they didn't need them. If they were just having high blood pressure without symptoms, they had a whole educational campaign to stop those PRNs, those as needed. And what you can see is that it worked. They were able to do that. And interestingly, when they looked at the balancing measures, they didn't find that the patients who are now not getting those blood pressure meds were having a lot of adverse outcomes in terms of rapid responses, ICU transfers, or code blue. They were the exact same before in the baseline period and after when they stopped giving the blood pressure meds for as needed high blood pressure. Same thing at Mount Sinai, where they created an algorithm to try to decrease the amount of as needed antihypertensives. And among the patients who did not receive IV medications based on their algorithm, there were no adverse events. So they were able to do this both at UCSF and at Mount Sinai, decrease the amount of blood pressure, as needed blood pressure medicine given without having adverse effects on the patients. So interventions can reduce those inappropriate treatments. And then finally, the other thing to keep in mind is if we do reduce people's blood pressure too quickly, it could actually be harmful. So this was a study that looked at the arterial blood pressure response to heavy resistance exercise. This looked at 5 healthy men who were in their early 20s, who were experienced bodybuilders, and they put an art line into them to see what their blood pressures were when they were lifting weights. And what they found was at baseline, their blood pressures were 135/80, pretty good, not perfect, but pretty good. When they started doing curls, that art line started reading 240/160, right? That's hypertensive urgency. If they started doing leg presses, they got up to 325/245. Blood pressures went through the roof, but their heads didn't explode and their kidneys didn't explode because our bodies are used to this kind of thing. Well, our bodies are made to deal with it. And finally, peak pressure for some of the patients went as high as 480/350. Isn't that absolutely crazy? There's also the study of autoregulation of brain circulation in severe arterial hypertension. And this looked at 10 patients back in 1973. Again, patients who weren't getting their blood pressure treated to see how the autoregulation system was changed for patients who had severe arterial hypertension versus those who had normal blood pressures. And what you'll end up seeing is the maps in terms of autoregulation are moved to the right for those patients who have really high blood pressure as compared to it being on the left for those patients who are normotensive. And what I mean by that is what you can see here is the patients who have maps of their blood pressures are 215/118, a map of 150. It really takes them to get below a map of 100 before they start seeing a reduced amount of blood flow to their brain. They don't see an increased amount of blood flow to their brain until they're, greater than 150 for this patient. And number 3, they're up at 200 or so, as compared to our patients who have normal blood pressure, who they start having reduced blood pressure to their brain when they're getting maps of below 60. So if you have a patient with really high blood pressure and you reduce that map really quickly, you can decrease that amount of blood going to their brain pretty darn fast if you get to maps that they're not used to anymore, where their autoregulation doesn't allow them to get enough blood to their brain. And we all know that that's true because there are lots of case reports of adverse events associated with aggressive treatment of increased blood pressure or strokes precipitated by moderate blood pressure reductions. So there are some patients who get treated who drop their blood pressure more than recommended and can have some really bad outcomes. All right, so the recommendations are when you get called about hypertensive urgency, don't just do something, stand there. Think about why they have high blood pressure. And is this high blood pressure new for them or not? I ended up slicing open my head playing squash about 10 years ago. And I went to the hospital, and at that time, when they took my blood pressure, I probably had what would be defined as hypertensive urgency, as I was freaked out about needing to get stitches in my head. Right? There are reasons that our blood pressure goes up that I certainly did not need any antihypertensives at the time. So think about, is this patient in pain? Is this patient having some kind of withdrawal? Why is it that their blood pressure is up? And instead of treating a number with PRN medication, evaluate the patient, allow them to rest, think about whether they really need blood pressure treatment or not. And then, of course, if they're supposed to be on blood pressure medicines at home and we didn't restart them in the hospital, which is the thing I always get consulted on by surgery, where they're like, I don't understand why the patient's blood pressure is elevated. And my answer usually is, well, because you didn't restart their diuretic and their calcium channel blocker, maybe we should do that. Well, then that's the easy stuff to do, the low-hanging fruit of this. And you can certainly look for opportunities to safely augment a patient's chronic hypertension regimen. Although, in general, I wouldn't change people's blood pressure regimen too much in the hospital because I think people's blood pressures are just wacky off while they're in the hospital. And really, you want to know what's happening when they're back to their baseline and at home.